University Hospitals of Leicester in the United Kingdom. And today we're going to go through some questions related to nephrology in view of the MRCP Part 1 exam. This is the first question. This is a question on a 28-year-old man who presents to the medical outpatient department with bilateral pededema and was diagnosed with HIV 2 years ago, but had not taken proper treatment and had irregular follow-up. His investigations are shown below, and your question here is what is the most likely diagnosis? So diffuse glomerulosclerosis, focal segmental glomerulosclerosis, membrane nephropathy, minimal change nephropathy, or nephrotic syndrome. The most correct answer here is a focal segmental glomerulosclerosis, and the reasons for this is highlighted in red here. This patient does have nephrotic syndrome as evidenced by evidence of swelling, a low serum albumin, and proteinuria. However, nephrotic syndrome is not a diagnosis in itself, and the most common causes of nephrotic syndrome in adults is focal segmental glomerulosclerosis, membranous, and minimal change. The clue in the question here is a history of HIV. HIV is associated with focal segmental glomerulosclerosis, and if you see a question with nephrotic syndrome and cancer, the most likely diagnosis will be membranous, as that is associated with nephrotic syndrome in certain groups of malignancy. But in this question, the answer here is focal segmental glomerulosclerosis, the cause of nephrotic syndrome due to his past history of HIV. A little bit more about nephrotic syndrome. Membranous disease is now being associated with a PAR2 antibody. So there's a specific blood test you can test for this. So if you see a question that mentions PAR2 receptors, then the answer to that question will be membranous glomerulonephropathy. As I mentioned, is associated with malignancy. The biopsy finding is deposition of immunoglobulins IgG in the basement membrane, fitting with the diagnosis. Minimal change is most common in children. You have a normal on light microscopy, and electron microscopy shows foot process effacement. The question will usually suggest the patient is young and renal function is usually preserved. Focal segmental glomerulosclerosis is associated with infections such as HIV, and as the name suggests on histology, there's focal segmental sclerosis with normal immunofluorescence. So if you given a question that tells you that there's anything to do with antibody deposition in nephrotic syndrome, the most likely cause is membranous. If there's no antibody deposition and there's changes, then it's most likely FSGS. And the final one to be aware of is amyloidosis. Amyloidosis often causes nephrotic syndrome and is classed into primary and secondary amyloid. The clue in the question would be Congo red staining. If there's Congo red staining, then it's going to be amyloid, in which case you have to decide whether it's primary amyloid, which is AL, or secondary, or defined as AA, which is associated with chronic infection. So look for clues in the question that suggest chronic infection or chronic inflammation and Congo red, and the answer will be with nephrotic syndrome, the answer will be related to secondary amyloidosis. This question is on a 55-year-old lady with a diagnosis of autosomal dominant polycystic kidney disease. All the family members are advised to go for screening for the condition. Which of the following were fit with the minimal ultrasound criteria for the diagnosis of autosomal dominant polycystic kidney disease? And the choices are below. Essentially, what you have here is ultrasound diagnostic criteria for adult polycystic kidney disease. And this really relates to when at what age do you screen patients and the number of cysts you pick up according to the age. So someone in this age bracket, you will then, who is 55, they will need to have 4 cysts bilaterally in order to fit the diagnostic criteria. So notice the number of cysts are important, but as well as whether it's unilateral or bilateral. Clinically, actually, this is rarely needed, as patients with this strong history of polycystic kidney disease will have multiple cysts, so hundreds of different cysts. But in the exam, when you get a question like this, you need to check to see the number of cysts, whether it's unilateral, bilateral, and age of the patient, and match it to the diagnostic criteria currently.